Please join me in welcoming Dr. Joshua Grill. Welcome, Josh. Thanks for joining us.
Thank you, Jennifer. Hopefully everyone can hear me okay. Thank you to the National Academies and the Beckman Center for the invitation to speak as part of this session. It's really a delight to join you. I'm only sad we can't do this in person, and I hope that we'll be able to return to fun and intellectually stimulating activities at the Beckman in person in the very near future. It's nonetheless my great pleasure to be here with you, our audience, this evening. Thank you for taking time out of your busy schedules to join this Zoominar. I'm going to start sharing my slides, and while I'll just say that, as you heard, I am a faculty member at UC Irvine and an Alzheimer's disease researcher. I spend most of my time working as part of our Alzheimer's Disease Research Center, or ADRC, that I'll tell you about at the end of my talk. I love this image and I love this topic. And what I'm going to talk to you about today is music and music's effect on the brain. And this image comes from the New York Times, and a really fantastic article that was authored by really the foremost neuroscientists studying music's effect on the brain, in my opinion, in the world, Robert Zatorre at the Montreal Neurologic Institute. And I think the image is clear that he, and he certainly has convinced me, believes that music can have a direct and profound impact on the brain. And hopefully I'll be able to convince you of that as well. And to do that, I'm going to try to, in the next 50 minutes or so, walk through three topics. The neuroscience of music, what happens to the brain when we listen to music, music and brain disease, and then I'll close specifically with music and the disease I study, dementia, with Alzheimer's disease being the most common cause of dementia. So to begin, I immediately borrow from Zatorre, and this image of a musical instrument, specifically a bone flute. This bone flute is actually made from the radius bone of a Paleolithic vulture. And as you can see on the top, it's been carbon dated to go back some 30 to 40,000 years ago. This is around the time of the emergence of agriculture and complex tools for human beings. And it tells us and shows us that essentially as far back as we can go in our recorded history, there was music. I mean, you can even see that it's a pretty well-made instrument. The holes on the flute are evenly spaced. If you look carefully, you might see lines in which it suggests a person was measuring in order to create this instrument. Music's been around as long as we have. It's ubiquitous. You find it in every culture, every geography, every society. It's useful. I can tell the difference in the pace I'm running depending on what song is playing and what beat it has. And marching armies keep the beat in a different way. And since you're logged into this talk, you'll probably agree with me that it's powerful, that it can convey strong emotions, can elicit strong emotions. It's evolutionarily conserved somehow. It's been with us for thousands of years, and it permeates essentially all of humankind. That's unique. There must be a reason for that. When we think about the neuroscience of sound, this is actually like a fairly old image from a textbook when I was a graduate student last century. And it shows the ascending pathway by which sound information, which of course enters through the ear and the auditory nerve, ascends in the spinal column to the brainstem and into what we call the primary auditory cortices of the brain, the cerebral cortex being our most human organ, and our cerebral cortex includes numerous primary sensory areas where we interpret information in this particular place, Heschel's gyrus, it's auditory information. And from there, we know that sound information can be distributed to other parts of the brain. But we also know, and this comes largely from studies of people who've had brain insults like strokes or brain injuries, or who experience some sort of abnormality in the way they receive auditory information, including music. We also know that music is uniquely processed in the brain. And again, using these studies where people have brain injuries, there's an accumulated knowledge that suggests we can point to particular parts of the brain as having roles in particular parts of how we hear and perceive music. And what you, I hope, can gather from the color-coded slide here is that this produces a map of sorts that is specific. We can point to specific regions of the brain that interpret specific aspects of music. It's distributed, meaning that it impacts both sides of the brain, for example, whereas we might think of certain things as impacting only one side of the brain. Music is bilateral in its brain activation. And this will be important throughout the whole talk. It includes an emotional construct. And not surprisingly, this comes from the emotional parts of our brain, some of the oldest parts of the brain, some of the most evolutionarily conserved parts of the brain. So there's the obvious implications of the primary auditory cortex. There's links to motor that make sense for things like dancing and marching. And then there's this emotional context as well. And for all of these, there are apparent neurological substrates. And this, amazingly, appears to be present at birth, if not before. This is an imaging study of infants. And what's shown is, and hopefully you can see my mouse, on the top row here is activation of the brain by music. And what's mapped, this color coding, is comparing brain activation during music listening versus silence. And so these orange spots represent differences between those two conditions. And what is played, and I'll give you an example of this in a moment, is normal music that we would all recognize as music, versus altered music that doesn't frankly sound musical. And you can see that even an infant's brain can distinguish musical sound from non-musical sound. And let me give you an example of this. Now I'm going back to Zatori's work, and he played consonant music that is normal and has rhythm, is in tune, etc. And he compared that to dissonant music. And before he put people in the MRI scanner, he asked people to listen to these two examples, or actually it was 6 examples of music that is consonant or sort of normal, if you will, versus progressively taking it further and further into dissonance. And you can see that people rated these levels of dissonance more and more unpleasant, as you probably experienced yourself. And then he showed by putting people in an fMRI scanner that when they were listening to these different musics, excuse me, not an fMRI scanner or a PET scanner, that this had a differential impact on the brain. That the activation of brain regions when someone was listening to these different pieces of music could be visibly detected, and of course statistically detected when analyzing their brain scans. And he showed that in particular the differences in brain activation between these categories was in those limbic parts of the brain that we think of as having a role in emotion. He also did one of the coolest studies I've ever known in my entire life. He took classically trained musicians who could reliably predict that a piece of music would make the hair on the back of their neck stand up, give them the chills. When I give this talk in person, I like to do a show of hands. How many of you have a piece of music that invokes such a remarkable response in you that it every time you hear it, it gives you the chills for some reason because it's so meaningful to you? He had the wherewithal, the brilliant idea to wonder, when that happens, when someone hears a piece of music that gives them the chills, what's happening in their brain? And he's a remarkably good scientist, so he did his due diligence. He showed that he could quantify this in people by looking at things like galvanic skin response and heart rate, and that these people truly could tell when a song invoked this response in them, and it didn't happen for other songs. Another really elegant thing about this experiment was the control group. The control group in this study was other people's songs. So he took all the songs that these classically trained musicians had that they said gave them the chills. He played all those songs for them, and he compared what happens in the brain when a person is getting the chills from a piece of music that does it to them to what their brain experiences when they hear a piece of music that causes the chills in someone else. And again, we see this very noticeable difference in the way the brain is activated when a person is experiencing this emotional response to a piece of music, very much in parallel to the galvanic skin response and heart rate response. And this again affected these very emotional components of the brain. The differences can be seen in things like the amygdala and the parahippocampal gyrus. And most importantly, the structure noted here, the ventral striatum and the nucleus accumbens. And he and his group and other groups went on to try to understand mechanistically. We knew that these particular brain regions were responsible for this phenomenon. Other groups went on to try to understand mechanistically what was happening instead of PET imaging, which was fluorodeoxyglucose PET, FDG PET for the experts in the audience. Other groups moved on to do raclopride PET. I should say his group did raclopride PET, easy for me to say, raclopride PET, which is a specific marker for dopaminergic activity, neurochemical in the brain called dopamine, and showed that it was in fact a profound dopaminergic response, in particular in the striatum part of the brain. And others used fMRI to increase the sensitivity and the regional ability to demonstrate differences in the groups, and showed again that these specific structures of the nucleus accumbens and some of the striatal structures of the brain. These are very emotional parts of the brain, and even more so related to what we call reward circuitry. And we think of dopamine as a rewarding neuro transmitter, the neurochemical in the brain. When we experience things that our brain wants us to do again, we have a dopaminergic response. So, our basic biological needs can elicit a dopaminergic response. Procreation, passing on our genes, can elicit a dopaminergic response. I've never put my wife in a functional scanner, but I'm very confident that when she's purchasing clothing and shoes, she has a dopaminergic response. She wants to do that again. This gets at the core sort of fundamental issue we began with. Music has been around forever. Why is it conserved in our brain? We are wired to want more of it, in particular when it is pleasant to us, or when it elicits this response in the form of making the hair on the back of our neck stand up. But does it have to be that? Does music have to be so intensely pleasurable that it elicits this galvanic skin response and almost a full body experience for the brain to act differently? Zatori next moved on to do a study that didn't include these classically trained musicians, and instead took kind of your average young adult in the hip Montreal music scene and asked them to participate, and played a large selection of music that was new to them. And here is the supplementary material from the paper published in the very famous journal Science of the bands that his group played for young adults recruited from the campus and off the street to listen to music that was new to them. I used to think I was cool because I recognized some of these bands. Those days are long since past, I assure you. But the point here was that those classically trained musicians, maybe their brains were unique because of their years of training in music. And maybe they had conditioned themselves in some way to react to that particular piece of music. But what if you take, if you will, normal people off the street and play music that they've never heard before? And in classic Zatori fashion, the elegance of the experiment was to play these pieces of music for these young adults, and while they were in the scanner, ask them, how much money would you be willing to pay for that piece of music on a music sharing platform, if you will, your iTunes or your Amazon Music? And the data are remarkable. They had 4 choices. They could say they were willing to spend $0, 99 cents, $1.29, or $2. And what you can easily see in this bar graph here is that the more the nucleus accumbens, this highly dopaminergic component of the brain, was activated, the more participants enjoyed the music and the more they were willing to pay for it. So a direct correlate in a naive population who has no musical training, that the level of pleasantness experienced by a person when they hear a piece of music is directly correlated with activation of the reward circuitry in the brain. And this was true for the nucleus accumbens and the caudate striatum. Again, all of these structures of the brain that are key in reward processing. So what does all this mean for just people in their lives, and can this go wrong, and what are the implications to brain disease? So to begin, I'm going to play 2 pieces of music, and I won't ask you to put it in the chat, but I'll ask you to think, what do these 2 songs have in common? The first one's a little loud, so I'm going to turn down the volume and apologize. Okay, I'll just tell you, that's Sean Paul. This song called Temperature hit the top of the charts in 2006. Here's song number 2. So the second song was the Doolies, clearly a different era, as it were, a different country, the UK. Their song didn't get quite as high on the charts, but still, made the top 20. I can't ask for volunteers about what those songs have in common. So the answer is that both of those songs are documented in the medical literature as causing seizures in human patients. This is a condition known as musicogenic epilepsy. It is extremely rare. About 1 in 10 million people suffers from this condition. The woman pictured here, Stacey Gale, and this condition does happen more frequently in women than men, though again, very rare. Stacey Gale suffered from this condition, and in fact, Temperature by Sean Paul was the song that she first recognized was causing her to experience seizures. She was Canadian and living in the New York State as a young college student, and was struggling that summer. That song made it to the top of the charts because it was everywhere in her life, and it was literally causing her to have seizures every time she heard it. Worse than that, her musicogenic epilepsy, as is often the case, expanded. It began to include other pop songs, so much so that it really impacted her social life because she couldn't go to parties and barbecues where that kind of music was playing because she would experience seizures. It expanded so much so that during her schooling, sometimes ringtones from phones would cause her to have a seizure. She ultimately, of course, sought medical care. They put her in a seizure unit, took her off her medications, wanted her to actually experience a seizure so that they could do high-density EEG and other clinical assessments of her. And it was days and she wasn't having one. And she eventually said to the doctors and nurses, "Oh, just give me my iPod," and she caused one to happen herself. This is a nice story. It ends up with a happy ending. She was a good candidate for neurosurgery that alleviated her of her seizures. But a remarkable case, a remarkable condition. Other commonalities among people who do experience this is it often is within a certain category of music, but again, it can expand over time. And it often is music that those patients enjoy. And a lot of epilepsy actually is temporal lobe in nature, those same parts of the brain that we were pointing to earlier in the talk as parts of the brain that can be activated by music. So a sad side of music. You may have heard of the very famous neurologist Oliver Sacks. Sadly, he passed away just a couple years ago. Wrote a number of very impactful, incredible books about the brain, about neurology. My personal favorite is called Musicophilia, in which he documents a number of just amazing cases that were presented to him clinically, or even more often through people writing to him to share their stories. One of the most remarkable is the cause of the title of the book. It's the case of a surgeon, if I remember correctly, again in the New York State area, who was vacationing with his family, and Sign of the Times went to use a payphone near where they were staying, and was struck by lightning. Walking across the parking lot, lost consciousness, woke up to a nurse, a Good Samaritan who happened to be nearby, who had resuscitated him. His first words upon being resuscitated were, "It's okay, I'm a doctor." Her response was, "A few minutes ago you weren't." He he was taken to the emergency room, given near a clean bill of health. They checked his heart, kind of checked his brain. He had some burns on the soles of his feet where the lightning had exited his body, but basically was told to take it easy for a couple of days and otherwise should be okay. He returned to his life as a surgeon, as a family man, but found himself waking in the middle of the night, seeking to listen to classical music insatiably. This gave way to a sudden desire to play piano, which he hadn't done in years, if not decades. He purchased a piano for his family's home. He started using essentially all available time when he wasn't performing surgery to practice piano and later to compose classical music. This got so extreme, he ultimately divorced his wife. She couldn't deal with it anymore, and he became a renowned, though amateur, composer and pianist. It's easy to imagine that lightning bolt changed something in his brain. And again, there are other cases, even cases of medication-induced musicophilia that can go away when the medication is taken away with anti-epileptic drugs. So music can ruin lives, as it were. But can it help lives? And of course, the answer is yes. Music, there are numerous studies to suggest that music can help to alleviate emotional and physical pain. Numerous studies, some of them relatively high rigor, suggesting that when music is used as a part of treatment, it can reduce the need for pain medications post-op, can be a suitable alternative to pain medications in some cases. A classic case from the literature, Annals of Neurology, a very famous, highly regarded journal in the space, a 1979 paper of a patient with Parkinson's disease. And for those who don't know, Parkinson's disease is a movement disorder, degeneration of the central parts of the brain that produce dopamine lead to challenges, tremor challenges like shuffling gait, eventually what's called freezing. And this particular case from the literature describes a patient of a neurologist who experienced a freezing episode and was locked in a position until suddenly a Sousa march came on the radio and launched him out of his Parkinsonian freeze. And if the person went on to say that he had taken to carrying a small device capable of playing music to help him if this should happen again. If only we had small devices that we could carry on our person at all times to introduce a musical treatment when we need it. Some of you may recognize this individual in the green jacket on the right. That's Gabby Giffords, the Arizona congresswoman who was shot at a political rally several years ago. She experienced brain damage as a result of her gunshot wound to the language centers of the brain. And she undertook a therapy that was developed primarily in stroke patients who have similar brain insults to the language parts of the brain. This is something that was developed by Gottfried Schlag at Harvard. And essentially, what is amazing about this is that patients who have a who have a left hemisphere stroke and lose the ability to speak will be extremely surprised to learn that they maintain the ability to sing. They cannot speak, but they can sing a song. And so Schlag used this observation that song was located on the right hemisphere and developed a program to train the right hemisphere to speak. And he did this by taking very commonplace songs like Happy Birthday, replacing the lyrics with common phrases used in our everyday language. So replacing it with I am thirsty, and then slowly removing the musical aspects of this so that what is left is the spoken word, instigated by the right hemisphere of the brain because the left hemisphere that normally does it has been damaged. And he calls this melodic intonation therapy. And Gabby Giffords was a patient who used this to improve her speech. Schlag has gone on to show that we can actually begin to rewire the brain when we do this and create an opportunity for patients to improve their verbal capacity, despite the left hemisphere that controls language in the overwhelming majority of us being damaged. What about music and memory? This is one of my favorite television shows. I'm going to play a quick clip from it. For those who don't know, this is the classic television comedy sitcom Cheers. The character on the left, played by Ted Danson, is named Sam Malone, and this is his coach who coached him in Major League Baseball. Neither of them graduated from high school. They were professional baseball players, and now working in this bar, they've decided to go back and get their high school degrees, and they're doing it together. And coach is a straight A student. Sam is really struggling, and he's asked coach to help him with his studies. So I love that piece. And I think this is probably familiar to all of us. When we teach our kids the ABCs, they learn it faster when we put a tune behind it. Is there a link between music and memory? Certainly we can use music as a mnemonic device to try to help us remember a list or a long acronym. But is there more to it? Can music actually improve our memory performance? There's the very famous Mozart effect, this idea that if we listen to classical music, it could actually improve our standardized test scores. This came actually from an original study here at UC Irvine. It really exploded in the scientific field, but ultimately was largely debunked, even though there were even animal model studies. The best thing to improve your standardized scores is to study. So music, whether it can improve cognitive performance in normal people, the jury's out. I would say the evidence is largely against it. But what about music in people who suffer from memory problems? What about music and dementia? So dementia is what we call a syndrome. Dementia is what I often refer to as an umbrella term. It means that a person is having problems with their memory and their other thinking skills, and that those problems are so severe they cannot live life the way they once did. They will ultimately rely on others to complete their activities of daily living. It's an umbrella term because under the umbrella there are many possible causes of dementia. There are very rare and very aggressive diseases like the prion disorders, such as Creutzfeldt-Jakob disease. We know that people with Parkinson's disease can experience cognitive problems and dementia. Call that Parkinson's-related dementia or dementia with Lewy bodies, depending on which comes first, the movement problems or the thinking problems. I'll talk briefly later in the talk about a somewhat more rare, earlier onset form of dementia called frontotemporal lobar degeneration, or FTD, which affects the frontal parts of the brain and produces disinhibition as a presenting symptom in most patients with that disease. But the overwhelming majority of patients who suffer from dementia suffer from the disease I study, which is Alzheimer's disease. It's estimated that some 60 to 70% of people who suffer from dementia suffer from Alzheimer's disease. What makes it Alzheimer's disease, aside from the fact that Alois Alzheimer first characterized it around 1906, is what's happening in the brain. And in Alzheimer's disease, we know there is an accumulation of primarily two abnormal proteins. We call them amyloid plaques and neurofibrillary tangles. And actually now, modern times, we can detect both of those through a variety of different types of tests, including some brain scans and measuring protein levels in the cerebrospinal fluid, or CSF, through something called a lumbar puncture or a spinal tap. So we understand Alzheimer's disease better than ever before, and we continue to believe that it is the underlying cause in the overwhelming majority of people with dementia. And in Alzheimer's disease and in dementia writ large, to some extent, we know that disease progression is a fundamental characteristic of this disease. People get worse over time. It can often be a long and slow, gradual progression of disease. It doesn't happen the same in everyone, but in many patients, perhaps even in most patients, while memory is typically affected early and often in the disease, other cognitive domains will ultimately be affected as well, including language and decision-making. But music can maintain its role in patients' lives and in their brains, often until the very latest stages of disease. Another case here from a very esteemed journal. It used to be called Archives of Neurology. Now it's called JAMA Neurology. This is from 1994 about a patient with Alzheimer's disease whose disease had progressed. His cognitive impairment had progressed such that he couldn't tie his necktie anymore. But he could still go out and play trombone in a Dixieland band that he had been a part of with his friends for decades. And this included even learning new songs on the trombone. I've developed an interest in this topic, and over the years, given this talk of more than a handful of times, I guess. And there was some press around my interest in this over the years, and a couple of times people shared their stories with me, and they were always remarkable. And I'd like to share one of them with you now.
My dad has Alzheimer's disease. He's 79 years old. It's been about 20 years since he last played the drums, but I still wanted to give it a try. 10 minutes after making this video, he had no memory of our performance together. But yet, he can still make music like this. I wonder why.
So first I gotta say, I think they both sound great. But you heard her say that he hadn't played drums in 20 years, and he sounded particularly good, I think. Why is it that this gentleman, her father, who was in an assisted living facility by this time, could suddenly just pick up the drums and play, even though his cognitive performance wouldn't let him live life on his own otherwise? This is a remarkable study in another esteemed journal in our field called Brain. This group scanned people listening to long-term musical memories, and they identified these regions of the brain I highlighted here in red as being the critical parts of the brain that were activated when we listened to music from earlier in our life. And then they compared this region, and hopefully you can see this outline here, to the regions of the brain that are atrophied or shrunken in a person with Alzheimer's disease. The most shrunken regions are in the yellow, red, orange colors. And you can see that this part of the brain is not shrunken at all. Then they compared it to the what we call hypometabolism, the areas of the brain of a person with Alzheimer's disease that don't use as much sugar. They're not as active as they were before they got sick. And again, the areas most affected, the greatest hypometabolism, are here in these warm colors. And you can see this long-term musical memory region is completely spared. And lastly, they compared it to where the beta amyloid plaques, the amyloid plaques that are hallmark of Alzheimer's disease, where those plaques accumulate in the brain. And again, the warmest colors represent the most plaques. And you can see that this region is largely spared even from the beta amyloid plaques. And so this suggests that there's a neuroanatomical substrate for music being preserved in patients with dementia, potentially very late in the disease, because these regions of the brain seem largely spared. Now, does this mean that we can use music as a treatment for people with dementia? It's a very difficult literature to examine. There's a lot of studies out there, which is great, but most of them are uncontrolled and difficult to interpret. As you heard in the intro, the studies that I'm a part of are what are called clinical trials. These are highly rigorous studies that we hope will change clinical practice. And the gold standard of these types of studies are the double-blind, randomized, placebo-controlled clinical trials. There aren't a lot of gold standard trials of music as an intervention. So it's a difficult literature to assess, and it's challenging as well because music isn't necessarily a drug. It's not a pill. We can't look at the dose per se. Understanding the implications of the individual's cultural beliefs, their musical past, their love of music, all of these things introduce potential confounds that can make it difficult to interpret these studies. And the literature is highly mixed. We see lots of different types of musical interventions. Some of them could be suggested to have exercise components, which we also study as interventions for Alzheimer's disease. Others could have meditation associated with them. So it's pretty tough. But overall, I would say that if we think about whether music can actually improve memory performance in people with Alzheimer's disease or improve cognitive performance in people with dementia, there are few studies for us to use to base our assessment. The ones that I discover in the literature are often quite flawed, meaning that the rigor of the design or the way they interpreted the results was really less than ideal. But most of these studies fail, and especially the good studies, the well-designed studies, fail to find a cognitive benefit. So not to be a total downer, but do I think music can improve memory or slow the course of Alzheimer's disease? As of today, no evidence has convinced me that that may be the case. But Alzheimer's disease includes lots of different types of symptoms. And though memory is often the first presenting symptom, it's rarely the most difficult for patients and their family members. Essentially, every patient with Alzheimer's disease at some point in their disease will develop what we call behavioral symptoms. These are extremely challenging for families. Early in the disease, they include things like apathy and depression. Later in the disease, they include delusions and agitation. These are extremely difficult for families. We have no FDA-approved treatments for these symptoms. And they're often the proverbial straw that breaks the camel's back, meaning that when these symptoms become unbearable, it's what forces movement of patients into skilled nursing facilities and other full-time care situations. We always recommend non-pharmacologic therapies for these patients, but these strategies are typically designed around introducing strong routine into the daily experiences of the patient, making sure the patient is getting activity during the day and sleep at night, avoiding triggers that might cause these symptoms, in particular toward the end of the day, the concept we refer to as sundowning, whereby these symptoms are most frequent and most challenging in the late afternoon and early evening. What if music could help with behavioral symptoms? There's lots of ways that this might be the case. First, music is something we can do with others. It improves social skills. Reminiscence therapy is a non-pharmacologic approach. We've already said that music and musical memory can be maintained in Alzheimer's patients. Maybe they have good memories associated with music and that helps their mood. We mentioned that in some cases, music, and in particular song, can be a form of exercise. And there's even literature to suggest it may have biological effects like lowering stress hormones. I'm going to propose another idea as part of this talk, however. These behavioral symptoms, again, happen in almost every patient, and we don't exactly know why. There are different theories for why behavioral symptoms occur. I outlined some of them here. It's a little bit beyond our scope for today, but I'll point out this last idea at the bottom here, a monoaminergic hypothesis. That is that particular parts of the brain are atrophying, are degenerating, are being attacked by Alzheimer's disease. And that produces chemical changes in the brain, including loss of dopamine, which we began our whole neuroscience of music with. Now, there's some interesting observations comparing people with Alzheimer's disease to some of those other forms of dementia that I mentioned under the umbrella. And I've already told you that in Alzheimer's disease, we believe that musical memory can be intact until late in the disease. This is in striking contrast to what we see in studies of frontotemporal dementia, where these patients have disinhibition, profound changes in personality, and in a handful of studies, experience a symptom in which they no longer recognize familiar music and they cannot recognize the emotional context of a piece of music. They can't say, oh, that's a happy piece of music, or oh, that's a sad piece of music. As part of their disease, they can't recognize that in FTD, whereas that is essentially always intact in Alzheimer's disease. And similarly, if we look at the substrates in the brain of these types of symptoms, I'm going to point right here to the nucleus accumbens. In Alzheimer's disease, the size of the nucleus accumbens isn't different from controls in one study, whereas in the frontotemporal dementias, we see the nucleus accumbens is atrophied. And again, this is part of that circuitry that we began the talk with. Same for the putamen, same for the caudate. So in these dementing disorders, where people lose the ability to interpret the emotion of music, the parts of the brain that are activated in all of us when we hear pleasant music are being attacked. But in Alzheimer's disease, they remain intact. And I mentioned that I used to receive a fair number of letters and messages from people who heard about my interest in this. And here I put some quotes from letters that people sent me about a program we once developed when I worked at UCLA, trying to bring music to people in nursing homes. And these quotes, which in the interest of time, I won't read right now, really said that people had discovered the power of music for their loved one with Alzheimer's disease, and that they noticed that it made their behaviors better, and that even the staff at nursing homes would comment to them about how powerful it was that they came there and listened to music with their loved one and how it improved their behaviors for some time thereafter. Unfortunately, again, the literature on this topic is highly mixed and not fantastic, but here's one study I liked. It was semi-controlled. It was a Korean group who had multiple nursing homes that were part of a study where they randomly assigned units of nursing homes to personalize music, where nurses went through with each patient and created playlists of music that they enjoyed. compared to piping in the, if you will, the elevator music that was the same for everybody. And they saw that the group that got the personalized music experienced a reduction in aggressive behaviors, whereas the control group who got the elevator music didn't experience that same improvement. It's not a perfect study. The behaviors didn't go away entirely, but it is, I think, a heartening example of the beginning of an evidence base. Another study I'll point to, this is, again, not a perfect study, not perfectly controlled. This was comparing participating nursing homes in, I'm failing to remember how many states were involved, participating in a program called Music and Memory, a fantastic program started by a guy named Dan Cohen, who I'll show you in a minute, that has the expressed goal as a nonprofit organization to bring iPods to every person in a nursing home in America. And they've expanded to Canada. And this study conducted by some academicians compared records from nursing homes that did and did not implement the music and memory program. So it's not a randomized study. It's not a perfectly designed clinical trial. But these findings here are still very compelling. In the programs that implemented the music and memory program, there was a greater frequency of discontinuing antipsychotic medications, which are used for these troubling behavioral symptoms, and a greater frequency of noted reductions in behavioral symptoms in those patients. So they didn't have to take these drugs that have a black label warning from the FDA for the risk of sudden death, and their behaviors got better in the absence, even though they were taking less medications. So really compelling. So to close, do we need a dose of music? Probably yes. Probably we all need a dose of music, and almost certainly people with dementia need their daily dose of music. And maybe music isn't enough. Maybe we need pleasant music. Maybe we need pleasurable music. Maybe we need intensely pleasurable music that can make the hair on the back of our neck stand up. There's no black box warning on music, and there's every reason to try it for patients with dementia whose quality of life might be improved by this. And there are a number of potential plausible ways music could improve quality of life for people with dementia and their family members. Maybe it can help treat these troubling psychiatric symptoms, but maybe it can help them to stay calm when they have to go to the doctor and take a blood draw or lie in a scanner in our research studies. Maybe it can help with the activities of daily living that they need help for ultimately as a part of their disease. And maybe it's a way for caregivers, family members to bond with their loved one on something that's still working in their brain. Maybe they can listen to music they shared decades before in their life and reacquaint themselves and their love for one another. I end every one of my community talks with what I call the 3 8s. I'm a researcher. Our mission is to find solutions for Alzheimer's disease. I'm very proud to be a faculty member at UCI Mind, the Institute for Memory Impairments and Neurological Disorders here at UC Irvine. We believe everyone can help us. You can do one of these 3 8s. You can donate, you can advocate, and you can participate. Everyone is certainly in a position to donate, but I might suggest you consider donating to Music and Memory if you thought today's talk was compelling. This is Dan Cohen. I really think this organization is amazing and outstanding, and I hope they achieve his goal of bringing music to everyone. On the Participate 8, I would alert our audience to what we call our C2C registry, or the UCI Consent to Contact Registry, which can be found at c2c.uci.edu. This is our effort to create a registry. We currently have around 5,000 people in this registry, and we've matched more than 5,000 people to studies here at UCI. It's free, it's confidential, it's low risk, you never have to do anything, it's completely voluntary. It's now available in English, Spanish, Mandarin, Korean, and Vietnamese as part of our efforts to diversify research at UCI Mind and at UCI writ large. We make this available to investigators across campus. And if you are interested in learning more about UCI Mind, the work I talked about today, or our research and educational efforts, there are some people listed here that you can reach out to. But the easiest and simplest thing to do is visit our website at mind.uci.edu. I'm sorry if I've gone a little bit over. I thank everyone for attention. I can see there are questions, and I look forward to answering them.